great. So we'll get started in 1 minute.
Is there a lot of people attending?
Yeah, this is recording, so okay, I will get started. Hi everyone, I'd like to introduce myself. My name is Helena Mistry and I'm the Director of Business Development at Amica. Thank you for attending our webinar today. The title is Diffusion MRI and Multiple Sclerosis and Why It Matters. Our speaker today is Dr. Ann-Marie Beaudoin. The format of today's webinar will be 30 minutes of presentation followed by 20 minutes of Q&A. So if you would like to answer a question at the end of Ann-Marie's presentation, please click the raise hand button and I will unmute you, or you can type the question into the question box and I'll read it out to Ann-Marie. So the total time for our webinar today will be 50 minutes. After the webinar, we'll be sending out a questionnaire. It's very short, so if you could fill that out and send it back to us, it really helps us plan for future webinars. And I'd also like to mention that we are recording today's webinar. So I'll start off by giving a summary of today's webinar, and then I'll tell you a little bit about the speaker. So a little bit about today's webinar. Multiple sclerosis, or MS, is an autoimmune neurodegenerative disease of the central nervous system, characterized by inflammation, demyelination, gliosis, axonal loss, and atrophy. Conventional MRI is sensitive to white matter changes in MS, but it lacks specificity for the underlying pathological processes. Advanced diffusion MRI methods have the potential to better probe white matter abnormalities by providing tissue-specific measures. Diffusion MRI is increasingly used to study white matter changes in MS, but standard DTI measures lack specificity to the different subcomponents of the white matter. In fact, the various pathological processes occurring in MS cannot be differentiated since they have a similar impact on the DTI tensor. Solutions have been proposed to overcome DTI limitations. Firstly, high angular resolution diffusion imaging, or HARDI, was developed to provide new anisotropy measures and to solve the crossing fiber problem. Secondly, since diffusion imaging measures are affected by the presence of free water in a voxel, free water imaging is used to obtain tissue-specific measures. Finally, advanced bundling and tractography can be used to investigate the impact of MS on specific white matter bundles. A little bit about our speaker today. Ann-Marie's passion for neurology began during her studies in physical therapy in 2009. And this is the main reason why she chose to change her career path towards medicine in 2012. She obtained her medical degree in 2016 at the University of Sherbrooke. She is currently a senior resident in neurology at the Centre Hospitalier Universitaire de Sherbrooke and a master's student in Sciences des Radiations et Imagerie Biomédicale at University of Sherbrooke as well. She is also a member of the Royal College of Physicians and Surgeons of Canada Clinical Investigator Program, and she'll be working in neurology as a clinician and a researcher in the near future. All right, Ann-Marie, I'll let you take over from here.
So, hi everyone. So thanks for inviting me today for this talk, and I'm very glad to talk to you today about the application of diffusion MRI in multiple sclerosis. As you understand, I am mostly a clinician, but I have interest in sciences and neurosciences, and this is why a few years ago I was introduced with Maxime Descoteaux, and we decided to work together. And I did a master in his lab, and I will present to you a little bit of my work as a student in the lab during the presentation. So let's get started. So first of all, multiple sclerosis is an autoimmune inflammatory neurodegenerative disease of the central nervous system. It affects 2.8 million people worldwide and approximately 90,000 Canadians. 75% of those individuals are women, and the age of diagnosis is usually between 22 and 49 years old. Canada is one of the countries with the highest prevalence of MS in the world, as you can see on that map. The main target in MS is myelin sheath of the neuronal axons inside the central nervous system. Demyelination will slow down the message sent along the axon, and if the damage is severe enough, the message can be completely blocked. There are three main types of MS. 89% patient will have the first, at first they will have a diagnosis of relapsing remitting MS, in which they will experience attacks of symptoms that will eventually resolve completely or partially. Eventually, there will be another relapse, followed by another remission period, hence the name relapsing remitting multiple sclerosis. After many years, a proportion of those patients can transition to secondary progressive MS, and that form of MS is characterized by slow progression of disability with or without relapses. There's also 15% of patients that will have a diagnosis of primary progressive MS. Those patients will experience disability progression from the beginning of the disease. So what do we know about MS pathology in the brain? In fact, the pathological hallmark of MS lesion is transient and focal inflammation with variable degrees of demyelination, axonal swelling, and transection. During the acute phase, the lesion will present an inflammatory cell infiltrate with reactive astrocytes, macrophages, and lymphocytes T and B. There's also focal demyelination, edema, and a relative preservation of axon. Thereafter, some lesions will undergo repair while others may fail to repair, and they will evolve into chronic plaques. In those lesions, the degree of demyelination, axonal loss, and gliosis, or scarring, will be more important. The neurodegenerative processes may extend outside the focal areas of the plaques. So we see focal lesions, but the processes will extend outside of them, and it will extend to areas of what we call normal appearing white and gray matter. MS is a diffuse disease, and global cerebral inflammation and atrophy is now well established. The exact cause of MS is still unknown, but there are two main competing theories. First of all, if we talk about the outside-in models, I will try to keep it simple for today, but it begins with activation of myelin-specific T cells in response to a myelin mimic epitope, and that epitope will be expressed on a pathogenic virus or other microbe exposure. So this is beginning in the periphery. Activated autoreactive T cells then migrate into the CNS, where they are reactivated and they start releasing cytokines, and this is what leads to myelin damage. On the counterpart, the inside-out model states that MS pathogenesis will begin with the release of myelin antigens from injured myelin inside the CNS to the periphery, followed by the presentation of myelin epitopes and activation of autoreactive T cells in the periphery. The activated T cells then migrate inside the CNS, where they are reactivated, and then they release cytokine, leading to further myelin damage. So the identification of lesions in the central nervous system by MRI is a critical component of the diagnosis workup in a patient that will present with symptoms that are compatible with MS. The typical lesions have an oval or elliptical shape and are usually located in the periventricular or juxtacortical white matter, as you can see on the image of a scan of a patient. It will also be predominant inside the corpus callosum, the posterior fossa, or the spinal cord. MRI is also used for the monitoring of disease activity, indicated by the visualization of new T2 hyperintense lesions or T1 enhancing lesions after gadolinium intravenous injection. This information will be used to guide further treatment decisions. MRI provides valuable information on subclinical disease activity. In fact, during the natural course of relapsing remitting MS, so the most common form, asymptomatic lesions will occur at a rate 5 to 10 times higher than what we observe by clinical assessment alone. So as you can see here, the inflammation is very predominant during the first phase of the disease, while neurodegeneration with axonal loss and brain atrophy are more important in the progressive phase. So as you can see on that diagram, the MRI events are quite common, but we don't always see it in clinic, and that's why MRI follow-up is very important. However, the association between clinical findings and worsening disability in a patient and the radiological extent of his disease defined by T2 lesion load is generally poor. This is what we call the clinical radiological paradox in MS. Some possible confounders are the inappropriate clinical rating, the neglect of spinal cord involvement, the masking effect of cortical adaptation, the underestimation of damage to the gray matter, and what is more of interest for us today, the lack of histopathological specificity, especially for axonal loss, and the underestimation of damage to the normal appearing white matter. So in fact, T2 hyperintense lesion will reflect the disease activity, and they are a general sign of macroscopic tissue damage. However, it's important to know that various pathological processes can cause the same image on conventional MRI, namely inflammation, edema, demyelination, gliosis, and axonal loss. So globally, you understand that everything that can happen inside an MS lesion have the same appearance, hence the need for more specific imaging biomarkers in MS. So diffusion MRI is increasingly used to study microstructural changes caused by MS in the brain. Diffusion Tensor Imaging, or DTI, has shown high sensitivity in detecting abnormalities in focal MS lesions. Also, it has high sensitivity for normal appearing white matter and also for gray matter. Globally, the cerebral tissue will show a decrease in FA and an increase in MD, RD, and AD when compared to healthy controls. These changes were associated with increased physical disability, decrease in cognitive performance, and an increase in fatigue severity and depressive symptoms. The problem is that standard DTI metrics also lack specificity for the different pathological processes occurring in MS. Here, the important thing to know is that, for example, demyelination and axonal loss will have a similar impact on the DTI tensor and metric, so they cannot be distinguished by standard DTI. In animal studies, a decrease in FA and an increase in RD were correlated to demyelination. In humans, DTI is more difficult to interpret, and there is no information relative to the amount of free water or axonal loss, for example. So how could diffusion MRI become more specific to MS pathology? Various advanced methodologies have been proposed to address this issue, and I will present today what we did in the lab to address different limitations of the standard DTI method. So first of all, high angular resolution diffusion imaging, or HARD, was used to address the crossing fiber problem. With HARD, we can extract some measures like the apparent fiber density. It's a measure that is proportional to the underlying fiber density, so it can be a marker for axonal loss. We can also obtain the number of fiber orientations, or NUFO, and it's also derived from RD, and it represents the number of local peaks of the fiber orientation distribution in each voxel. This measure provides information about the complexity of the underlying white matter organization. We also use the free water imaging to extract free water corrected diffusion MRI measures. Here we call them FAT, RDT, and MDT, where the T is for tissue, And with these, we can investigate the degree of demyelination. We can also extract what we call the free water fraction as a marker of edema. So free water imaging, it's in fact a B-tensor model where there's a tensor for the tissue part and another one for the free water part. The advantages of the free water imaging is that the corrected measures are thought to be more tissue specific than when we compare with the standard DTI-derived metrics. Also, free water fraction can offer valuable information about active inflammation and edema. So we did a diffusion MRI project to study the effect of relapsing remitting multiple sclerosis on young patients' cerebral white matter in Sherbrooke using an advanced diffusion MRI methodology. We recruited 24 patients with relapsing remitting MS, and they were compared to 11 healthy controls. The imaging study included a multi-shell acquisition with RD, advanced local modeling, including fiber orientation, distribution function, and free water imaging. We used probabilistic tractography with a lesion-corrected white matter mask, advanced white matter bundling, and finally, bundle-wise statistic with tractometry. So, for the white matter mask, we did a manual and automatic segmentations, and they were fused to produce the lesion mask that you can see here in yellow. And it was covering all the white matter lesions that were visible on the T2 FLAIR and T1 weighted MRI images. The probabilistic tractography based on FODF peaks, as you can see in C, was executed, and tracking was allowed through the lesions, as you can see on the FA map showed in B. Without this correction, no track would have been generated inside the yellow mask. And as you can see, we can have bigger lesions or multiple lesions, and that would have been a major problem in MS patients if we didn't track inside the lesions. So here I present you the studied white matter bundles, and those were segmented from the tractogram of a 23-year-old woman who had a diagnosis of relapsing remitting MS 5 years before the beginning of our study. And she was treated with natalizumab, that is a disease-modifying treatment in multiple sclerosis. The extraction was made with the tool RICO bundles, and the track segmented from the participant data were visually assessed to ensure the quality of the bundle extraction. According to the current knowledge of the different function of the white matter fascicles of the human brain, we chose the corpus callosum, the fornix, cingulum, IFA for inferior fronto-occipital fasciculus, the inferior longitudinal fasciculus, the superior longitudinal fasciculus, and the uncinate fasciculus. They were selected as bundle of interest. We chose those bundles because their function is restricted to the brain, and their function would not be affected by lesions inside the spinal cord. We didn't do tractography or study of the spinal cord, and we really wanted to study bundles restricted to the brain. Also, the selection of a restricted number of white matter bundles was made to minimize the number of statistical tests and to avoid false positive results. So in our study, we found an increase in free water fraction in bilateral fornix and in the left IFA, and the free water fraction values were consistently higher in the relapsing remitting MS group. Interestingly, the lesion volume of most of the white matter bundles was strongly associated with their respective free water fraction, showing the important contribution of the lesion tissue in the estimated volume of free water. In a neurodegenerative disease like MS, this is a new parameter that can be very useful to indicate active inflammation and edema. We also found a decrease in FAT and an increase in RDT and MDT in 11 of the 14 bundles that were studied. And this is, according to previous literature, a sign of diffuse demyelination in relapsing remitting MS patients. Also, the apparent fiber density was increased in 8 different bundles, and we hypothesized that this was due to diffuse axonal swelling. The fact that this metric was not decreased also indicates that axonal loss doesn't seem to be important at that stage of the disease. Finally, the number of orientation function, the NUFO, was increased in 4 bundles in the relapsing remitting MS group, indicating an increase in white matter organization complexity. As said before, there was no sign of significant axonal loss according to our results. So, that being said, why is it important to be more specific to the underlying pathology in MS? First of all, increasing the specificity for tissue subtype and associated injuries can help better understand the sequence of events happening during the different phases of the disease. We know that in relapsing remitting MS, neuroinflammation will be predominant in the first years of the disease, and eventually neurodegeneration will become more important and inflammation will subside. In our study, we have indicators of edema, axonal swelling, and demyelination. Axonal loss and atrophy will occur later in the natural history of the disease in the secondary progressive phase. Also, we now know that MS is a diffuse disease and that inflammation and neurodegenerative processes extend well beyond outside focal plaques. So advanced imaging methods can explore the normal appearing white matter, something that conventional MRI is unable to do. By studying the lesion tissue compared with normal appearing white matter is of interest because it can reveal extensive abnormalities in the brain of our patient, and it can help us better understand the different types of changes occurring in MS patients. In the lab, this is part of future work. Also, another subject of interest in MS imaging is the increasing concerns about long-term health effects of repeated gadolinium injections. Also, the enhancement characteristic provides an incomplete characterization of the lesion, the underlying pathology. So it would be great to have another option than gadolinium injection to distinguish between acute lesions from older, more chronic lesions, because our patients are quite young and they are subject to repeated MRI, so they will in their life have a lot of gadolinium injections for the follow-up of their disease. So with diffusion, FA values were shown to be significantly decreased in enhancing lesions when compared to non-enhancing lesions. Also, there are there's others imaging sequences. One of them is the quantitative susceptibility mapping, or QSM, and it has been proved to have a good performance in discriminating between both types of lesions. So this is a great avenue for research. In the last 20 years, there has been a rapid evolution in MS treatment. So we started with no treatment at all before the years 90, and now we have a lot of molecules that we can offer to the patient depending of the aggressivity of their disease. Now the new trend in MS treatment is remyelination. So it's an area of great interest, but currently it lacks a robust imaging marker. Advanced diffusion MRI in combination with myelin-specific MRI contrast, such as myelin water imaging or inhomogeneous magnetization transfer can provide measures potentially applicable in remyelination clinical trials. And that would be interesting to see in the future. So I have a few more minutes to talk to you about what we want to do in the future in the lab with Maxime Descoteaux's team. First of all, it would be interesting to do a prospective study with our cohort that we studied in 2017. The goal would be to see if there are prospective changes over 4 years, to see if there's a change in the radiological extent of the disease, and also if there's a change in the symptoms and severity in those patients. The interesting thing to explore here would be if there's a correlation between the progression seen clinically and at the diffusion MRI. So this is a project that we want to build for 2021. Another interesting project that is currently ongoing is to see if we can be sensitive to progression of the disease over a short period of 6 months. So what we want to do is to compare relapsing remitting MS patients to healthy controls that are sex and age matched, and to see over 6 months with 5 different MRI if there's a signature of the disease during that short time. We want to see if there's a difference in progression between the two groups, and also if there's a correlation between that progression of the disease and the changes in cognitive performance, in fatigue severity, in depressive symptoms, or motor symptoms. So this is a project that we are currently at the visit 1 for most of the patients, and we are excited to see the result that will come out of this. So in conclusion, I can say that MS is a very complex and heterogeneous disease, and I think that multimodalities imaging protocols with advanced methodology will be important to better understand MS at the different stage of the disease. And I think that we will need the help of researchers, people in neurosciences and informatics, clinicians. If we all work together, probably we can better understand the disease and also better help our patients. So that's pretty much it. I would like to thank all my colleagues and supervisors and at the Department of Neurology of the CHU here in Sherbrooke, also the people at the CIL and at the Research Center of the CHU for helping me during my studies. And yeah, I will be available for question now.
Okay, great. Thanks, Anne-Marie. So our first question comes from RJ Tessie. His question is axonal loss due to demyelination or independent of demyelination?
The question is the axonal loss independent from demyelination?
Is axonal loss due to demyelination or independent of demyelination?
Okay, so what I understand is that when the inflammation is severe enough to cause extensive demyelination, the axon will lack the protection and the support of the myelin, and it can lead to a transection of the axon. But what I also know is that in MS we have damage to the cortex, so the gray matter, and you can have Wallerian degeneration, so the axon can be degenerated because the body of the neuron has been attacked. So I would say that axonal loss has many mechanisms. So loss of myelin is one of them, but the axon can be lost because of of a more cortical mechanism.
Okay, great, thank you. Our second question comes from Daniel Bradley. Have you followed these patients over time?
A few of them, I saw them in my clinic, so I've been in touch with them. The project that we want to do this year, so 4 years after the project, will be the time for me to see how they are doing. So all those patients are in the clinic of the multiple sclerosis clinic at the CHU. So they are still all followed there, but I am not their personal physician. So no, I don't follow them regularly, but this year, hopefully, we will be able to see everyone, to do physical tests, cognitive performance tests, to see how they progress during those 4 years.
Okay, great, thanks. Our next question comes from RJ Tessie again. Is there a correlation between demyelination and axonal swelling?
I am not sure that I can give a complete answer to that. Axonal swelling for me was quite a new concept. I know that it's happening. It has been shown in animal studies and in human studies. I know that ex vivo studies showed axonal swelling in the brain, but also in the spinal cord of the specimen that were analyzed. And also there are some teams with advanced MRI technologies that they saw the axonal swelling. But I don't know the exact mechanism under the axonal swelling, and I'm not sure that we know it yet.
Okay, great. So our next question comes from Daniel Bradley again. Did you look at any cognitive clinical assessment?
Yeah, I was worried about the time, but I see that maybe I would have had the time to talk about that. Yes, we did some tests for cognitive function. So with those patients, we did the symbol digit modalities test, so the SDMT for mainly working memory and also information processing speed. So we did that. We also did the paced auditory serial addition test. So the version 3 seconds. So the PASAT, that is also for cognitive assessment. We did also 2 questionnaires. So one for fatigue severity. So it's an adapted French version for Quebecers of the modified fatigue impact scale. And also we did the depression questionnaire, that is the Beck's depression inventory version 2. So we did those tests, and also we searched for correlation between diffusion MRI abnormalities and the results of the questionnaires and the tests in our patient. Unfortunately, we had a very small cohort, so they are 24 patients, and they did quite well during the testing, probably because they are quite young and the disease is well controlled for the majority of them. So we only found a correlation between fatigue severity and abnormalities of diffusion in the right superior longitudinal fasciculus. This bundle is not known to be involved in fatigue in what I saw in my literature review. So I cannot explain it totally based on what we know of that bundle function, but this is what we found. But I think if we add a bigger cohort and also with patients that are more advanced in the disease, probably we would have had a better correlation. And this is one thing that I want to explore with that cohort 4 years after, as their performance changed over 4 years, and now can we see a correlation. But in the first study that we did, that was kind of a a pilot study. We were testing things. No, the correlation was not there, but we looked for it.
So our next question comes from Maxime Decoteau. How do you explain asymmetries in tractometry findings? For example, difference in the left hemisphere and not the right hemisphere. Is this expected?
What I think is that most of all of our patients were right-handed, so their dominant hemisphere is the left one. We know that the brain will have speciality between both hemispheres, so maybe it can explain sometimes what we find that the right SLF, for example, is implicated and not the left one. I think that if we are about to see like that one bundle is implicated, for example, in cognitive function or decreased processing speed, I would expect that both sides would be implicated. So maybe when you only see one side that is correlated to a symptom, maybe it's just lack of power, or maybe it's just that your cohort by total hazard, the lesions are more on one side or the other. But I don't think there's an anatomical explication for like clear-cut difference between right and left. That would be my answer.
Okay. Our next question comes from Daniel Bradley. Can you hypothesize why NUFO is higher in MS subjects versus healthy controls, and where healthy control age matched? Is NUFO an effect of age or disease duration, for example?
Okay. So for NUFO, what I understand is that when it's increased, there's more, the number of local peaks that we identify in a voxel is increased. So I have two hypotheses. They might be wrong, but my hypothesis is that if there's a pathological process at one spot, maybe there are some reorganization of the white matter. And sometimes we can see like sprouting of the remaining tissue that is not lesioned, can reorganize, and this is why we think that some lesion will not give symptoms. So maybe the reorganization of the tissue can have multiple directions, so the NUFO could increase. Another thing that I might suspect is that, as you can see in an active inflammation lesion or plaque, there are a lot of cells that are coming in, and maybe those little macrophage and astrocytes and oligodendrocytes that come in and try to repair the lesion tissue, maybe all that, what in French we call it an inflammatory soup, maybe all those little cells that come into action, maybe they are acting like mini peaks, and maybe we can capture them. So that would be another hypothesis. I think there was a sub-question about age-matched controls.
Yes, that's correct.
Okay, so in the first study, we did an effort to have the same bracket of age. So most of patients, I think the mean age in MS was 26 years old, and for the healthy controls, they were like 28 years old. So when we did a statistical test, it was that the mean age was different into the two groups. So the MS group was a little bit younger, but clinically, between a patient of 26 versus 28 years old, for me as a clinician, it was not a big issue. for the age, and also they were not like paired, so age and sex match. But this is why in the bigger study that we are doing right now, this is something that we did just to be sure that those were not some confounders. Yes, but at first, yeah, we did an effort, but they were not matched properly.
Okay, our next question comes from Max. Is there a publication of this work that we can read?
It's coming. So the publication is under review right now. So yes, there's a paper coming hopefully soon.
Okay. Our next question comes from RJ Tessie. Demyelination occurs outside of lesions. Are the areas of progression to lesions seen by traditional MRI?
Can you repeat just the end of the question, please?
Do the lesions of progression to lesions, are they seen by traditional MRI?
Okay, so traditional MRI, the only thing that you can see is like the T2 hyperintense lesions that you can like see pop up every time you do your follow-up. So you will probably, with conventional MRI, what you see is lesions that were severe enough to produce that T2 hyperintense signal. But we now know that outside of those lesions, there are proof of demyelination and inflammation. So conventional MRI doesn't show the extent of the disease. It only shows areas where it was severe enough to cause a visible symptom, a visible lesion. Sorry. But we know that outside those focal lesion on T2 flare, that the disease is active outside of it, and that's the major problem. And it's been like more than 20 years that people tried to use conventional MRI as a prognosis tool. So like we know that people with really active disease during the 2 or 4 or 5 first years, we know that their prognosis is less good. But when we take cohorts of patients and we just look at what we call the T2 lesion load, it's just counting the lesions, and you see how they progressed in life. It's not very good as a correlation. And we think that it's because conventional MRI only count the lesion, and it's not taking into account the cortex. It's not taking account what we call the normal appearing white matter. So we don't have a global idea. And that's why the correlation with the prognosis for a given patient is not that good. Like I cannot say to a patient, so you had 10 lesions on your scan, so in 7 years you will walk with a cane. I cannot do that. So it's not powerful enough right now. So I don't know if it answers the question correctly, but this is what I would give as an answer.
Okay, great. We have a question from Manon Ed. Manon, go ahead. Manon, you are unmuted, so you can ask your question. Okay. So Manon, if you want to type your question in the question box, I'd be happy to ask that to Anne-Marie. Our next question comes from Max again. What is your opinion on the outside versus inside theory of MS?
Okay. For many years, I was taught that the theory of MS was the outside-in theory. So that it started in periphery, that your immune system was not regulated good enough. It has seen, for example, a virus. The virus that was the most studied in MS is Epstein-Barr virus. This is very interesting. I think that most of the patients at the clinic are positive to the Epstein-Barr, so the mononucleosis virus. And it was thought at first to be like the trigger of the disease. So if someone was genetically predisposed to the disease and the EBV, so the Epstein-Barr virus comes into the bloodstream, it can trigger the autoimmune, the autoreactive T cells, because we think that on the virus there's a mimic epitopes, and then the system goes chaotic, goes inside the brain, and activate the inflammation responsible for MS. I was taught that theory many years ago, and I thought it was real. But what I understand is that now we are not sure. I am slowly leaning towards the inside-out model, because I think it's a very good hypothesis to say that it starts inside the brain. My opinion is that in the few next years we will have better explanation about the mechanism, but I think that we are going to switch the paradigm towards the inside-out models, just because it's not everybody that has Epstein-Barr virus or other virus that will develop autoimmune disease, and I think that MS is very complex and probably it starts inside the brain.
Okay, our next question comes from RJ Tessie. Can we design an MS trial using this technology, or is it too early?
I know that a few clinical trials are using DTI. I think mostly because it's quite simple and people are getting used to DTI. What I think for advanced diffusion imaging, I think that if, like right now, the acquisition time is ready for the use in clinical trials. So it's quite short, it's quite easy to do on 3T scanners that are available in multiple centers. So this is okay. The hard part is the processing. So to do a clinical trial with a lot of patients, you need automatic processing and you need automatic QA. If you only rely on individuals like me or a master student to look every bundle, to visually assess the quality of the data, after that to run the statistic, to make the manual and automatic segmentation of the lesion, to do your mask, every step is very time consuming. So I think that when everything will be automated and be reliable, like if we have good test, retest, reproducibility, and everything is faster for processing and to obtain the results at the end, I think that the technology in itself is ready to use in clinical trials. I think it's only that it's very time consuming and we need to be more time efficient, because with a big cohort of patients, it would take hours of just treating the data and cleaning everything. So I think we will get there, but maybe we are not ready yet, but it's coming.
So my next question comes from Manuel Ed. You presented your results on the average bundles. Do you plan to see if there is a difference between the streamlines which pass in lesions and those which do not?
This is something that I wish I had time to do. That would be very interesting to compare the lesioned tissue between and what we call the normal appearing white matter. So to take a bundle and to separate what is a lesion on T2 versus the rest of the bundle. It's a very good idea. I think we should do it. I personally lacked time during my master to do it, but I think it's a very important exercise to do to better understand what it means inside the lesion. Like what we see in T2, what's the difference? Why do we see it on conventional MRI and why the rest doesn't show up? And is it because the demyelination is very intense? Is it because it's edema? So yes, it would be a great project to do. Yes.
Okay, so that's all of our questions for today. Thank you, Anne-Marie, very much for your great presentation. So I would like to thank everyone for attending today. Again, just a friendly reminder, please fill out that questionnaire. It's very short, I promise, and it will help us plan for future webinars. Thanks, everyone. Have a great day. Bye now.
Thank you. Bye-bye.